Hey, everybody. It's Michelle, and I am completely cup runneth over with joy because today I get to announce that Chasing the Swallow, Truth, Science, and Hope for Pediatric Feeding and Swallowing Disorders is 100% done and in publication, and you can check out your copy on Amazon. And the best part, if that book moves you, if it grows your evidence-based triangle to engage in interprofessional practice, to do the root cause analysis to why the child is presenting with the PFD, to then engage with the team to get that child to a point of healing so that the real growth can begin, then y'all check out speechtherapypd.com because they are gracious enough to entertain all of these amazing, joyful ideas. And they're currently carrying the book for 13.5 ASHA CEUs. So thank you for being a part of the First Bite journey that led to Chasing the Swallow. And be sure to check out speechtherapypd.com for the 13.5 ASHA CEUs that accompany it. Happy learning. Hi, folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by speechtherapypd.com. I am your host on this nerd venture, Michelle Dawson, MS, CCC, SLP, CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention right there with you. I run my own private practice, Heartwood Speech Therapy, here in Coletown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts.
To break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every fourth episode, I join in. I'm Erin Forward, MSP, CCC, SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by speechtherapypd.com. Hey, everybody. I am absolutely humbled by the guest that we have today. And I am grateful for how our guest came on today. So a huge heartfelt love of gratitude to the one and only Dr. Rocky Garcia and her fabulous, brilliant, and sassy self because Rocky came on back the tail end of June for episode 190. And that's how we concluded Dysphagia Awareness Month. And she talked all about hypoxic ischemic encephalopathy and pediatric dysphagia. And she also shared this amazing book, and I have it right here, so I'm pulling it up. It's called HIE, Lights of Hope. And when she shared her passion, she also informed us all about hope for HIE. And here we are a few months later. And y'all, we are blessed and lucky and fortunate to have none other than Betsy Pilon, the executive director for Hope for HIE. And I'm just, I love a good backstory, and I love interprofessional practice through interprofessional education. But first and foremost, I love elevating caregiver voices, and I love a good love story. So that's kind of why we're here today. So Betsy, thank you for coming on. Hi.
Hi. Thank you so much for having me. I'm so excited to be here.
Yes. Okay. So tell me all the things, what is Hope for HIE? I'm going to get ahead of myself because I have like 4,000 questions, but I love nonprofits. So yay, lay it on us, honey.
All right. Well, I will, I guess, start in the beginning and my beginning. So my involvement with Hope for HIE started in May 2012, shortly after my son Max was born. So Max was my first child, had never heard of HIE. Like many out there, thought that the NICU was for preemies, and Max stopped moving when I was 37 weeks pregnant. And thankfully, I had known about kick counts, so I did those. We had called into labor and delivery, and they told me to do some kick counts, and if I wasn't comfortable with how that turned out, to just head on in to get checked out. So I thankfully got in very quickly. Unfortunately, I didn't have any kicks that were to be counted. And so we just thought we'd be that couple that goes in and got, checked out and discharged and something we'd laugh about. But that was not our story. So my husband and I headed into labor and delivery. They hooked us up, did an ultrasound, a BPP, biophysical profile, and noted that Max was not pre-breathing and that his heart rate variability was stable but not moving, and that he was in distress, so they needed to get him out. So this was definitely not the entrance to parenthood we expected. They prepped me very quickly for an emergency C-section. And as they were prepping me and the anesthesiologist came over, who was, I don't know if it's just like the trade that they have to be calm people, but he did an excellent job of calming me down. And as they're going through their list of, saying you might have to be intubated and like we could knock out your tooth accidentally and all the things they have to tell you, I had a panic attack, which actually got Max moving because of the adrenaline. So,
okay.
which ended up being a blessing in disguise because he said, oh, look, I don't think we're, and the OB-GYN that was there said, I don't think we're going to have to put you under because he started moving. And we'll just get him out urgently. I'm like, okay, great. So,
okay. Oh my God.
So I actually was, blessing in disguise, right? I was awake for his birth, which unfortunately many of our families are not because of the situation of needing to get them out quickly. And so Max was born at 1 a.m. He let out a little cry. The neonatologist was in the room and intubated him almost, as soon as they could get him over to the isolate. They knew he was going to, need that support. And then we began our journey into care. We were told about an hour after he was born, and they had been giving him assessments, that he qualified for a therapy called therapeutic hypothermia, which is newborn brain cooling. And we had no idea really what that meant. I had worked for the health system that I delivered into, and we were at the health system's community hospital. And I had actually, by Providence, had worked with the NICU team down at the main hospital in downtown Detroit to develop, because I was in marketing and communications, to develop a brochure that talked about the transfer protocol for other local community hospitals that would need a level 4 NICU. So I actually knew I had met with the head of the NICU. I had met with nurses. I knew who was coming to get my kiddo. And so we were kind of like, we did not realize how serious it was. We just, had implicit trust in the team to get him what he needed. So he was transferred. They were able to secure a bed for me. And so I was transferred down a few hours later. Thankfully, my parents are local. So at 3 a.m, when we called them and said, this is what the situation is, they came over to be with me. My husband, Mike, followed Max's ambulance and my parents followed mine. And then Max began his, descent into cooling upon arrival. And it was pretty scary. So we didn't know how scary, but we know that, we were told later by the nurse practitioner in particular, they had a really hard time, even keeping him on, a ventilator. He had to have the higher level oscillator for the first 24 hours. And it was just a really, scary unknown time. And again, we didn't, expect any of this. So it was definitely a shock that we were in that situation. And so then, we went through our NICU course. He was in the NICU for about 3 weeks. We got discharged with not a lot of information. And, at that time in particular, we were told like, oh, don't go home and Google, it can be scary and overwhelming. But also I said, well, are there other families you can connect us to? Because with HIE, there's such a broad range of potential outcomes.
Yes.
So, and I was thinking like, there's got to be someone else that's gone through this. Like, there's got to be a guide out there somewhere of what life might look like across the variety of outcomes. And so I am stubborn and went home and didn't listen. And thank goodness I didn't, because I combed through the internet, like, a week after we got home and were settled in, and found 3 blogs of 3 different parents. And they all pointed me to a Facebook group called Hope for HIE. So that time there were about 200 to 300 families all around the world. So it was a pretty small group. And instantly I was like, oh my gosh, yes, these are my people. And everyone had a similar story of, they were near full term and, like HIE, there was explained or not explained, and, don't go home and Google. And they went home and Googled and found each other on the internet. And so, as someone that had worked in the health system and disseminating, patient education materials and things like that and creating them, I thought, gosh, we've got to do better for families like this. This is not okay that there's this lack of information and lack of connection. And there's, just a ton of resources for preemie families out there. But our population, was really left out. And so the founders of that group had intended to create a global nonprofit. They had started that process and then, came up against some roadblocks. So in 2013, a couple of us got together with the blessing of the group's founders and said, hey, can we get this going? And they said, yes, absolutely, take it and run with it. So we worked on founding it as a nonprofit. With such a global group, we had to find a place to, plant a flag in the ground. So I had a lot of really wonderful resources and friends who are very talented and volunteered their time to help us out. So we planted it officially in West Bloomfield, Michigan, of all places.
I got to be honest, I haven't heard of that
right?
one.
I know. And, Metro Detroit.
Okay, this I have heard of.
Yes. And our goal really initially was just to let people know that we were out there and to, to make the internet less scary. So to have a web presence, to, build out our social media so people could just find and connect, because we found that just being a part of that peer support really made a huge difference. I mean, it made a huge difference for me personally. Time and time again, people were saying like what a difference it made to them. We started informal meetups and getting people together in person and connecting. And that was when really the magic kind of started moving for Hope. So, now it's 2022. We've been at this for, a few years now. I've been in the HIE community for 10 years, just over 10 years now. Max is now 10. And it's been quite a journey and constantly evolving. So, the first couple years of the foundation were, like I said, really focused on building the framework. So getting some educational materials put together, getting some referral materials put together, trying to get those into NICUs. And then we just really have had this renaissance of growth since about 2019. And now we're involved in, research and in, quality improvement project. In addition to, the core of our organization, the heart of us is still very focused on support. So as a growing organization, we were able to bring on a social worker this year and run some social worker led support groups. And we're planning on offering, we're able to offer starting next year some, counseling sessions with that social worker for those that need it as well. And we, have a robust peer support network. So we have peer-to-peer support that now connects over or almost 8,000 families today. And from all over the world, we have peer support mentor programs for newly diagnosed families. And then for, unfortunately, those that may lose their babies or children to HIE. And then foster ways for other people to connect in a myriad of ways, sibling support, dads, pride parents, location-based, whatever ways people need to connect on the topics and ways that matter to them most.
This is phenomenal. Okay. So many questions. I volunteer a lot with Feeding Matters, right? Their peer-to-peer for caregiver to caregiver mentorship is free. So as a clinician, if I'm picking up a patient, because I do community-based therapy, so I do in-home or like at a clinic. So I get the little ones after they've been discharged from the NICU, which is fantastic. But oftentimes when they're discharged from the NICU, there's that sudden drop off in services. It's not necessarily automatically carried over to the state early intervention system and so forth and whatnot. So there's a lag time there. But am I allowed to refer a family, or is it family referral back for caregiver support? How does that work?
You absolutely can refer a family. So HIE is very complicated, as we know.
Yes.
And so we launched this year. HIE Awareness Month is in April. And we can talk for hours on all the things that we have going on. But we launched in April a dedicated landing page that is a quick reference and quick referral, HIE.support. So basically you just type into your web browser, HIE.support. That has connections to our social worker who can do intakes. It has our, links to our peer support network that's based on Facebook. There's applications to get in our peer support mentorship program, which is that one-to-one peer support mentoring. Again, it has some, basic educational materials as well linked there. So you can try to make it as easy and quick as possible to get people connected.
Love this. Okay. So folks, if you're new to the world of early intervention, or if you're new to the world of pediatrics, one of the things historically that has not been taught well in the field of speech pathology is caregiver counseling and caregiver empowerment. So let's take it back to Maslow's scale of hierarchical needs. Us going in as clinicians, or the infant being brought to us, or pick your setting, right? If that family is at a level of crisis, if they're in their trauma, if they're in their valley, then anything we attempt to do will be lost. We have to set them for success. As our sweet friend Erin says, it's okay to sit with them in their grief. It's okay to sit with them in their anger. And our job is to empower. And this right here is an opportunity for empowerment. This is an opportunity to say, hey, I know this organization that has this unique skill set. Let me connect you and educate. So that's why once upon a time, we all had to study the Maslow scale of hierarchical need, folks. This is it in action. Okay. Also, if it's not too forward, how your little one is only a couple months older than my oldest. So could I ask how y'all are doing and the joy and yes.
Yeah. So Max is 10. Max, which is unbelievable. He starts 5th grade this year, which It's just unreal. He, I like to say, is living his best life every day. So is he without impact from HIE? No. Does he live an incredible life? Yes. So Max, and we'll go back to the NICU. So Max, was able to feed orally beginning after he rewarmed, and he was a sluggish feeder, but never needed a feeding tube of any type, either NG or otherwise. So we're very fortunate that he was able to. It was a stressful time. I mean, certainly I can't think of anything more stressful for myself or our family is than, figuring out feeding things. And if your child does have some impacts, neurologically that impact feeding, it's very stressful. So, Max was the baby that met like the minimum feeds that they wanted him to do for a very long time. And so we got discharged. He was not on any supports other than, it's pretty standard, although this is changing as well. When you talk about seizures, which HIE is the leading cause of neonatal seizures, typically babies are either bolused on a anticonvulsant like phenobarbital, or now they're so Max didn't have any clinical seizures on his EEG or anything when he was in the NICU. Now, 10 years later, the research has come such a long way that he probably would have been weaned off that medication before discharge. Now, with him, he was weaned off by 3 months. But, his feeding difficulties, he was just always a sluggish feeder. He wasn't very good with breastfeeding. So he just, pumped and fed for a very long time, and that was really, his big thing. He was slower with gross motor development. He has microcephaly, which is just a small head as a result of his HIE. So, which again is kind of something that I think takes parents by surprise in this journey. And so, and he has a vision impairment. He is mobile. He started walking when he was 3 without assistance. He uses AFOs to this day, so orthotics. He has mild spastic diplegic cerebral palsy. He does have a vision impairment where he did not develop depth perception. So he learns to navigate his world. And so new environments are a little tricky, but once he learns them, he's good with steps and all of that. And he's doing great in school. He is at grade level and everything. He does have an IEP. His supports and services, are exceptional and help him, get where he needs to be. And he, outside of the medical side of things, he loves basketball. He loves superheroes. He loves Metallica. I broke his heart yesterday, though. I asked him, I was playing a song on our Alexa or whatever, and he's like, "Oh, this is old music." He's like, "I want to play Metallica." And I said, "I hate to break it to you, this kiddo, but I said Metallica is old music." He's like, "What do you mean?" And I said, "Metallica's been around as long as I have in the world." And he was devastated. So, because Metallica is his very favorite, and he thought that they were new. So,
That's him and my Goose Danger would get along great. My Goose loves Led Zeppelin. Like, he loves Led Zeppelin. And okay, so mommy listens to K-Love Christian radio station and then rotates it out with Dropkick Murphys and Irish punk rock. And my husband is all over the place, but Led Zeppelin is his jams. And he was like, "They're so cool." And my mother-in-law was like, "I saw them live back in the day." So she now walks on water. I'm like, that's amazing. Also, was it a cortical vision impairment? My older brother-in-law has microcephaly, CP, cortical vision, ASD, and a whole host. So
he's never been diagnosed with CVI. We were told that it was delayed visual maturation. Is it on the spectrum of CVI? It could be. He just hasn't been tested for that. He does have a low vision consultant that works with him to set up, the classroom environment, make sure he has all materials, enlarged a little bit and set up for his success with school. So we just haven't officially got him tested, but CVI obviously is very, very common with HIE. It's one of the leading causes as well. So it wouldn't be surprising if, he had some, if he was on the spectrum of that as well.
Yes.
But yeah, so that's, it's a part of his life. And, like I said, he falls probably a little bit more because of the vision than the CP. And so we just, do our best to help him acclimate to those environments and be cognizant of, but he's a 10-year-old boy. So he also wants to, run and do all the things. So it's a balance.
There's something horrifying that happens between 9 and 10. And it's all of a sudden they smell. And I buy deodorant for Goose and but he's just funky. I love him. Goose, if you're listening, mommy loves you very, very much. This will pass. I promise, Bubby, in 2 or 3 years. Just don't transition to the Axe body spray. Okay, let's skip that stage. Also, if you're a mom and you have a son in that body spray stage, more power to you, love. Okay. So on that note, folks, if you're listening, some of the things that we're talking about, because we do, Betsy, we do have clinicians that are familiar with some of the terminology that we threw around. A CVI is a cortical vision impairment. Oftentimes, those of us in the community assume that when a child is discharged from the NICU, that they're coming home with all known potential outcomes and etiologies diagnosed. However, that is, honest to goodness, probably the opposite of what happens, right? So it's on the community-based clinician to empower the caregivers to know what signs and symptoms to look for. So if you have an infant and you're working on those initial first feeds and you notice a lot of startle reflex engagement when a bottle breast or nipple is placed or a spoon is presented, those are sometimes some of the first red flags that there's a field of vision loss. And a cortical vision impairment is not the same as nearsighted or farsightedness. This is a occipital lobe optic nerve component that has been compromised or did not fully develop or was damaged due to all of the above. It could be absence of cortical structures, a bleed in the cortical structures, pick it. There's so many potential outcomes. But that's one of the things that we're talking about. But before we go too far down that one rabbit hole, because I would go do that with my ADD, let's talk about what is HIE and how that can influence feeding and swallowing.
Yes. So HIE stands, as you mentioned before, Hypoxic Ischemic Encephalopathy. So, part of what we do as an organization is try to help families understand these complex medical terms, because it's important that they learn them and it's important that clinicians use them as well, because sometimes that can be a barrier to connection and care and education. But basically hypoxic, so, lack of oxygen, ischemic, restricted blood flow, encephalopathy impacting the brain. So neonatal HIE occurs in about 2 to 3 per 1,000 live births in developed countries. In underdeveloped countries, it can be upwards of 20 per 1,000 live births. It's crazy. And it can also have other names like perinatal asphyxia or birth asphyxia or neonatal encephalopathy. There's some complications that we can talk about with why HIE sometimes is not named. But essentially, it is the largest type of neonatal encephalopathy out there. So, and it is something that has a myriad of causes. The majority cannot be prevented. Placental issues, cord compression, cord entanglement, things like that. So we see a lot of cord, a lot of placental issues. It can happen during delivery. And so it is something that, many are at risk for. So placental abruption is a cause, uterine rupture is a cause. So, we see just a lot of, if it's like if anything can go wrong, will go wrong sort of with birth, sometimes can end in HIE. So, but again, it has a wide range of outcomes. So it's staged according to the Sarnat scale, which was developed in the 70s. So the Sarnat scale has actually been around for a while, but the therapeutics really did not become effective until cooling, which we'll get into as well, I'm sure. But yeah, basically a myriad of causes. There's 3 different stages: mild, moderate, severe. And most of the therapeutic research and therapeutic options have been available for moderate to severe, not necessarily for mild, but that's changing as well. And a whole host of outcomes ranging from very mildly affected to loss of life and anything and everything in between. Any way someone can be affected with a body system could occur with HIE. So, the most common, the very most common, I mentioned neonatal seizures. That can also be a lifelong epilepsy. And that can also occur later on in childhood. Max actually did not, like I said, develop neonatal seizures. Likely because he was on phenobarb, it was suppressed, but he did go on to develop epilepsy at age 8. So, and he's not alone. There's a lot of long-term outcome data that is now being tracked. We've seen it now in our community for quite a while of the different waves of impacts that can come up for kids that, might get signed off at age 2 or age 3 with early intervention or with even outpatient developmental clinics. And then families come back at, school age and see learning and attention issues and behavioral concerns. And there's a higher incidence of autism and, things like that. So in epilepsy, the second, say, most common diagnosis is cerebral palsy because it impacts the brain. It can impact, motor function, impact fine and gross motor, obviously speech, swallowing, all the oral motor, issues that can come from cerebral palsy and impact speech and swallowing. So obviously feeding therapy is a big one for our families. Speech
Yes,
therapy.
it is.
Yep.
And folks, this does not need non-speech oral motor exercises because we know the evidence does not support that utilization. Thank you again, Dr. Georgia Malandraki and the Purdue I Eats Lab and Dysphagia Research Society and current evidence-based practice. Yes, sorry.
You're good. I love it. Keep throwing it in. So for our families in particular, and I know that I'm sure Rocky spoke about this as well, there is such a need for earlier intervention in the NICU course to get, to improve those outcomes for these babies in particular, because there's even research, and there's another paper that just came out last week that was published from Italy.
Wait, can we just acknowledge the enthusiasm in your voice when you said, and there's another paper? I love that because I'm like, oh, did you see the new research article? Yeah. And your soul's joy would just hit mine. So continue.
Yes.
Research from Italy. I'm with you.
Yeah. So, we're, as an organization, obviously patient advocacy is a huge part of what we do. And so, when another paper comes out about feed the babies, we're like, yes, let's do this, so, and showing that, forever they've been restricted with cooling. So, and I don't know if this is a good juncture to talk a little bit about cooling.
Go. Yes. Yes.
Well, we'll back up on that for a moment, but basically, so the gold standard of therapeutic offering right now for HIE is therapeutic hypothermia, where you cool a baby down to about 91 degrees Fahrenheit for 72 hours. You slowly you slowly cool them down, you slowly rewarm over 12 hours each time. And traditionally, they withheld, babies were NPO across the board, no matter what their vitals were what their stability was NPO, gold standard. And no touch, no holding, no nothing during that, because you want to keep a consistent temperature for the cooling to work. And cooling has been shown to reduce death and disability. And I think it's important that we talk about those two things because it's not a cure, but it is the best that we have to improve outcomes right now for HIE. And it's great. It was a game changer and has been a game changer. But there's obviously much more we need to do because, that when you look at that, it's yes, we're saving more babies. That is very important. What are their outcomes like, right? And how can we continue to improve the outcomes within this context right now as other therapeutics come online, right? So the latest research, there was one, I believe it was last year, that was published in The Lancet, which was a meta-analysis from the UK of all these cohorts of kids in the NICU, and showed that there was no adverse effects. There was no increase of neck. There was no increase of, anything else of babies that showed stability to introduce trophic feeds. So that was huge. And this is something that we just keep trying to talk about more and more. And so this secondary paper, or new paper, I guess I'll be very respectful to the authors because I respect that they did the work as well, out of Italy, shows the same thing, feed the babies. There's no, if they're, obviously there's, clinical indicators, if they are not hemodynamically stable and things like that, maybe you want to take a look at it. And, and there's indicators of who would be the best, to introduce feeds to versus not. And so, but they see that the fed babies during hypothermia decrease their NICU stays, which we know is important because we know that getting babies home helps improve outcomes. They're less likely to get infections. They're less likely to, they're more likely to, increase bonding in that maternal bond. And it's the same thing with holding. There have been holding studies now that, like they are able to show Alexa Craig, who's out of Maine Medical Center. She's doing amazing work.
Wait, what is her name?
Alexa Craig. She's a neonatal neurologist and pediatric neurologist. And she has done, her study showed they took cortisol levels and they tracked the cortisol levels of mothers and babies when they were held versus not held. And no surprise, the cortisol levels were lower for the babies that were stable enough to be held during cooling and safely during cooling. And the cortisol levels dropped for mom and baby. And of course, they were higher for those that were not. So again, that marker allows us to show that those babies they also had less NICU stays, or less length of stay. So we're looking at these things now where hopefully standard of care is moving towards, feeding the babies earlier, holding babies earlier. And as therapists, we asked this, I spoke and I met Rocky in person. It was amazing. I spoke with someone that she works with as well, Dr. Monica Arroyo down at Joe DiMaggio Children's, who's a pediatric neurologist, about introducing therapies earlier as well in the course. And we asked the poll, at the NANT conference about when, what is your protocol at your NICU for getting therapists involved earlier during cooling? And there really doesn't seem to be, a standard. And a lot of people won't even put the orders in until after babies are rewarmed, And so that you're missing out on potentially 5 days, which is huge to see.
Those are their first reflexes.
Yes.
That's I can't even fathom. Okay, you just gave me a couple of different ideas on how we could engage in improved dissemination of information and research. Okay.
So that's something that, and this was it was such a wonderful opportunity. Everyone was so eager to talk about, how they could go back to their NICUs and say, hey, how can we do this? How can we get involved earlier? So that way we can start on these, we're working with these babies and families, earlier in the course and building those relationships and, seeing how this can improve outcomes. So it's really, really exciting to be where we are right now because as a parent, my experience now 10 years ago, and so much has changed in 10 years, but, it still continues to be that therapists, the NICU therapists, unless you're respiratory, are thought of definitely more as an afterthought as opposed to an integrated day one team member,
I mean, heavens to Betsy's. In the community, I get a script and I'm happy if it says peds dysphagia.
Right.
I can't tell you how many times I get one that says peds aphasia, which is a word retrieval difficulty for patients post-CPA.
Yes.
And I'm not working on anomia with a 4-week-old, and that's literally it. I mean, case in point, yesterday I went in and did an eval on a little one, and I saw signs and symptoms of 3 incidents of 5 to 9 seconds in duration of focal seizures. Oh, by the way, he's 2.5. And this is the first time he's been referred to early intervention. And I'm like, has your doctor brought up? Have we talked about this? Because, all I have is a script. And and I know that all of that seizure activity is causing trauma to the brain. Yes. And she was like, well, I think we have a referral to neurology. And I'm like, oy vey, this is not okay. But it's, y'all, this is where we're at. So we have to advocate for improved outcomes. Okay, so we have to have a sidebar because I have an idea, but we'll do that afterwards. So folks, stay tuned for Squirrel 1180 Gabillion. Okay, all right. When you're at the NANT conference, can you explain what that is? Because I'm only familiar with it in the periphery because of Casey Lewis and Rocky Garcia and their NICU work, but can you talk about what that is?
Absolutely. So that's the National Association for Neonatal Therapists. And so it is the premier organization connecting neonatal therapists, moving forward the field and looking at, evidence-based practice, moving forward standards of care. It's led by Sue Ludwig, who is a phenomenal advocate in this space. She is the founder of NANT. She's a good one to follow as well. She actually just published a book. She's phenomenal. She's like the light and sunshine of the world. She is an OT by trade, a neonatal OT, and has done this work for several decades, building NANT. And the conference I've been to several conferences before in the neonatal space. And I have to say, NANT was one of the most energized, amazing, heart-filled conferences I've been to. There's something very different about therapists that is just so wonderful to be around. And just the energy, kind of fun. The collaboration, the fun, and really, neonatal therapists are, for, as in the outpatient setting, they are the ones that set the tone in the relationships that could be with these families forever, for their childhood and into adulthood. For many of our kids, obviously, they will be in therapies long term. And so getting those relationships and that understanding of the benefits of therapy in the beginning, getting those referrals are, as you said, we see it all the time too, these families that slip through the cracks. We want to stop that from all ends, from the therapeutic angle, from, the clinician educational angle, from the patient advocacy angle. We are trying to stop these families from slipping through the cracks. So when they do find us, from frantically searching and go, wow, I didn't know that this, why didn't I know about this sooner? We say this all the time, time is brain. And, it's not, we don't want to, that can be a lot of pressure on families. So we don't necessarily on the family side, we try to let them know that neuroplasticity is a lifelong event and possibility. But we do know that the earlier the research is there. We know this. The earlier you intervene and more consistently you intervene, the better the outcomes. So, there's so many things that when we talk about quality improvement, communication improvement is a huge one. And so, when we spoke to Dr. Arroyo and I spoke to, to the therapists at the NANT conference, and the conversations we had were, they're like, some of them were sharing with us what we already know is because of many different reasons, which I think are all not great ones. Clinicians are nervous to even name HIE. And so because if you go to Google and why, people didn't want to say it for so long, unfortunately, there is an elephant in the room where there is a certain percentage that may have a medical legal implication from causation. Now that doesn't impact, that doesn't impact the care in the NICU because this is after the fact, right? People are taken care of if there was something that could have been prevented or went wrong that could have been prevented.
You're talking birth trauma.
Yes. Yep. And so a lot of our families, and where we, again, lots of work to do, never a shortage. We have these lovely risk management departments, and bless them for all the hard work that they do. That is important work, but they've scared these clinicians from even naming a clinical diagnosis, which is a key part of this child's medical information. And they withhold that on the advice of risk management sometimes, which is wrong. And people know this, the therapists, openly said that. They're like, what do we do to prevent, to open this conversation in a way that keeps us away from the causation part and just talks about getting them educated in accurate information. And everyone deserves that. That's an ethical thing, right? You don't withhold medical information. That's you get in trouble for that, except for in this case, right? Like,
no, folks, it is literally in our code of ethics to code to the highest level of specificity. And so on a clinical end, if you're treating a child that has an oropharyngeal dysphagia and it's secondary to HIE, then you have to start at the beginning and code backwards. You have to code R1312, which is the dysphagia. If you're in the NICU, it could be acute pediatric feeding disorder, which is R63.31 or 32. I'm rusty. I'd have to have it. And then code the causal factor. If it's an intraventricular hemorrhage, if it's hypoxic ischemic encephalopathy, we have to code that. And that's our legal, ethical responsibility. And if your hands are being tied, then this is where you advocate. And also you advocate within your institution, within your company. And that's why you have a state association. And typically there's somebody on there called the VP of Clinical and Professional Affairs or VP of Governmental Affairs. Those would be your liaisons that you can reach out to. And behind the scenes, they can network with different associations, maybe your hospital association to raise awareness, maybe your Department of Health and Human Services. I mean, these are all things I've seen in action occur for the betterment of the patients that we're called to serve. But you need to know what you're legally and ethically responsible for doing. So, sorry. Yes, just had to give a couple pointers there.
That's great. No, I mean, I feel like this is, for me, I have always enjoyed having difficult conversations. But, because I if there's a barrier, let's talk about it and break it down. That's what it comes down to. And so, we know that has been a barrier to care. And so let's find a better way of communicating. So that's, part of the work we've been doing too is, working with clinicians and speaking, at different conferences and things to give people ideas of how to even foster these, conversations in a way that is the right thing to do by the family, by the child, and, within the framework of the organizations they work in. So that is, something that continues. It has improved significantly over the years. But it is still a mountain that we are, tackling step by step. But it's so wonderful when we can do it together.
So I have a dream, and I'm going to put it into the universe because this is a patient safety issue. If we are all identifying, I just rubbed my eye makeup off. I can't believe that because I was thinking too hard and I rubbed my makeup off. That's great. If we're all identifying these point of system failures, then, and it varies greatly by state, and I get it, states' rights, but patient rights, in my opinion, trump that. And if we're seeing this, then wouldn't it be awesome to have a federal policy such that when a patient discharges, that there are federal guidelines in place for these little ones that are medically fragile on the pertinent information that immediately gets sent over to the state EI system so that it's not falling into an abyss. And folks, if you're listening and you have this capability to join in on this fight, I would suggest a list of current medications, a list of current known medical etiologies, a list of, therapeutic restrictions, because some of our babies, they come out and they've had a heart transplant, they've had surgery, they can't do certain activities for endurance because maybe they have congestive heart failure. I'm just thinking of like my cardiac babies because oftentimes they have restrictions, right? As such, they should. And a copy of the most recent discharge records. Like, this is what happened. What if, in a perfect world, all of that information immediately went from the NICU straight to the state EI system, and the EI system had a document that physicians and allied health members and the service coordinators could access? Like, that seems so freaking obvious, but the fact that we haven't gotten that up to snuff. So how do we go about doing that, Betsy?
Well, I think this is when we talk about federal EMR, right? So, that certainly, and, I think we're moving towards that. I think there's some good things. I mean, obviously our world has been reformed through this pandemic, right?
Yes, ma'am, it has.
To say the very least, right? But some of the good things that have come out of that are the acceleration of interoperability with EMR. It's great. So, so I have a medically complex child, despite his, again, doing very well in life. He's still high maintenance. So we are MyChart users, like super users and insurance super users and navigators. And, the ability to, they got their COVID shots at CVS and it's in their MyChart,
Yes.
That is fantastic. Like, why didn't we do that before? Like,
yeah,
for anything, that should all feed with that. He had surgery at a different health system. Now those MyCharts are connected, so I can go back and forth between and make sure that, all of that's, his pediatrician has access to all of that. Why did that not exist before?
Mm-hmm.
So, we love in this country, obviously, there's a lot of feelings about a lot of things, but, the benefits of having that interoperability at the very least outweigh, any sort of political whatever garbage that is out there, because we know as the users of this on the patient and provider side, how incredibly helpful it is for the optimal care to have access to that information. Families now, I mean, even, we see this, it's, one of the things about EMR, like your discharge summary has all of those coded diagnoses on there. Before it didn't. They had to request medical records, right? So families now are saying, what is this hypoxic ischemic encephalopathy thing that no one told me about during the past 3 weeks of my child's NICU stay? What is that? And then they're nervous to ask about it. So they go to Google and they find us, but they, so it's improved in that way. But it needs to, they shouldn't be hearing about it first in the discharge summary. They need to be hearing about it at point of diagnosis, So that's part of it too. But the possibility for improving communication and getting that information, so you as an outpatient provider can know that birth history and medical history of your patient, allows you to obviously give optimal care. It allows families to get optimal care. And we know that that's going to improve outcomes again. So that's, that is definitely, anything that, that is out there legislatively that they're pushing to have more of this interoperability. Let's do it. Let's sign on to that. So we do that as an organization all the time. We are a part of many different collectives that have these sign-on letters to advocate, for these, this infrastructure to build. And I would say it's a positive thing to come out of the pandemic, is that we are moving forward in such a much better way, of that information share.
So I'm thinking big picture, we would have to pull ASHA, AOTA, the Pediatricians Association, y'all, NANT, any Neonatology Association, and federally DOE together to create a policy. But I could actually see that. I mean, all good things come to those who wait, but also those who advocate. So,
well, and there is some federal, I think there's some federal advocacy that has been done for preemies. So now this is another, as we're in, NICU Awareness Month, and talking in other circles as well about equity in NICU representation, the preemie forces again came together and said, we need a better pipeline for, into early intervention. And they should be guaranteed to, if you're a preemie, you're guaranteed to be an EI for 3 years, right? We don't have that for all kids at risk. I would like to make the case that all HIE kids should be as well, because, in changing those follow-up protocols, because we have these kids that are in and out, they'll spurt ahead in one thing and then, then they have to get re-enrolled because they'll get out of it, or by 6 months they're like, oh, they're fine, and then they're not fine by 18 months. So it's, there's just a whole lot of variability with the EI programs too, in this country. With even, I'm in Michigan, it varies, ours is administered on the school district level, others by the county level. It just, it really depends on where you live. And who qualifies. And so, we need to be, any child that's at risk from the NICU of neurodevelopmental disorders of any kind need to be tracked, period. Right. So that's where I'd like to see some of these other initiatives be more inclusive of who that impacts, So it's not just the preemies. it's if we're going, forward with neonatology and all these providers from the NICU forward, into neurodevelopmental land, that needs to include all that are impacted by that. The heart kids as well, it's a lot more. And again, that's resource dependent, but there's a lot of room for improvement for sure.
Mm-hmm. I love you. You're amazing. This is wonderful. Okay. All right. Okay. We have like 5 minutes left, and I do need to circle back around to like how we can like support, HIE and hope for HIE. But what can you talk to us about when we first start that early intervention walk, assuming that everything happens smoothly? Oftentimes we're in there at the start and we don't get to see the long-term outcomes and the long-term prognosis. But what are potential outcomes for down the line?
Yeah. So, I think, again, it's anywhere from, and the brain is just so wild because every HIE child is going to have, even if they have a similar MRI, picture of how they were impacted on an MRI, they're going to every single brain is going to repair or move forward in a different way, regardless of therapies, it's wild. So you have such a wide range of outcomes, but, we see kids at, so Max's peers that are more impacted from HIE, at age 10, they're going into 5th grade as well. A lot of them have AAC, so getting that communication going earlier is so important. The emphasis used to be solely on mobility, but kids need to communicate. So find a way to communicate. So, like when we move from the swallowing and feeding to communication, and all of them are important, making sure that families, because we know as some of these kids grow, if they do struggle with feeding, that sometimes a G-tube is going to make their lives better for everyone. That actually improves quality of life for many because they're not spending hours a day trying to feed their kids, and they can spend those hours a day on AAC and giving them a means to communicate and doing fun things as a family,
Yes. Okay, folks, on that note, yes. The second there is, so excited. Words are hard. We presume competence. We do not need to start with antiquated methodology with taking nouns and printing them on pictures and then having a child pick between two nouns. Once you know better, do better. You can utilize communication devices and set up free trials for your patients and get a free long-term loan for yourself to bring in speech-generating functional communication devices in early intervention. I have worked with it with little ones as young developmentally as 9 and 10 months of age, okay? And there are entire organizations such as Control Bionics and Talk to Me Technologies, and they do not pay me to give their names. I just love them, that will guide you through every step of the process. And there is no out-of-pocket expense to the families because they work with the families to get everything covered by insurance. So please, please, please reach out to those organizations and empower these caregivers and empower these little ones to thoroughly enjoy their lives. Yes. Oh my gosh. Yes.
Big thing. So our mission at Hope for HIE is to improve the quality of life for children and families impacted by HIE. So quality of life, again, is subjective, but it also does not have to be like, we want to make sure that kids are kids, and therapy is going to be an important part of their life for many of them forever. But what does that mean? And how can we work together to make sure that these families and these kids get that chance to reach their potential? I love that. We talk about presuming competence all the time. There's another, when we talk about peers, Max has a peer who has spastic quad CP, nonverbal, and he's been, he's on grade level with everything. He, has been in a gen ed inclusion setting since the get-go. His mom has flown around the world to start him on AAC early which is really kind of pioneering because he is the same age. So 10 years ago, this really wasn't happening like it is today. The field has just soared and continues to. And so, and he loves Star Wars and living his best life. He's living his best life, right? And it looks very different than Max's life, but it's awesome, and he has friends and he's going to school and, he's able to articulate through his AAC, his frustrations as well. So he's seen, a therapist to work out his frustrations with, dealing with his disability as well, which other people would think, oh, well, that's not possible. It's absolutely possible. And he's getting the support to do whatever he wants to do in his life. And it's so important. And that's that. And that came from a team thought and mentality with a very passionate parent and very passionate clinicians who believed in his potential.
Yes.
So,
okay.
Yep.
Yeah.
There's that.
Yes. Clap. I got nothing. This is why we do the thing that we do. Yes. Okay. As my grandma says, the one that raised me, sometimes families have a little bit of love money left over at the end of the month. So if anybody's got a little bit of love money, how can they support Hope for HIE? What can we do? Where can they find you?
So I mentioned earlier, HIE debt support is a way that you can, if you have someone to refer in, a family to refer in, you can also just go to our main website, which is hopeforhie.org. And, we're across social media, across as many platforms, I think, as possible, at Hope for HIE. So we have that consistently across the board. We'd love to hear from you. We'd love to hear what you're doing, and how we can better collaborate as an organization. We do obviously gratefully and graciously accept, support of many different types for our support programming and other organizational initiatives. And you can read all about that on our website. We have like a NICU and PICU support, care package program, hospitalization support, loss support, all of that, that is funded directly by our donors. So, we are grateful for any and all support, even just, following our social media, sharing it again with families. That's what we want the most, is to have people connect and know they're not alone.
Yes. Excellent. Betsy, thank you. Thank you so much for the work that y'all are doing on behalf of our families and our patients. Rocky, I am in awe. I am in awe, sweet friend, of the beautiful people that you bring together so that we can raise awareness and put joy and hope and light in this world. So thank you for being the best of us.
Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together. That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I am your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And as always, remember, feed your mind, feed your soul, be kind, and feed those babies.
Hey, so it's Michelle Dawson here, and I need to lay out my disclosure statements. So if you ever wondered how bad my ADD, ADHD, and lack of sleep Monday through Monday actually is, well, here you go. These are my non-financial disclosure statements. I volunteer with Feeding Matters. I'm a former treasurer with the Council of State Association Presidents. I'm a past president with the South Carolina Speech Language Hearing Association. I am a current member of both ASHA and SCISHA. And for this year, for 2021, I volunteered for the Pediatric Feeding Disorder Planning Committee for the ASHA 2021 convention. My financial disclosures. All right, so I receive compensation for First Bite presentations as well as talking teletherapy and understanding dysphagia from speechtherapypd.com. I also receive royalties from speechtherapypd.com for ongoing webinars that I have on their website, as well as compensation from PESI Incorporate for a lecture course webinar that I have on their website as well. I am coordinator for clinical education and clinical assistant professor for the Masters of Speech Language Pathology program at Francis Marion University in Florence, South Carolina, for which I receive an annual salary. I also receive royalties from the sale of my book, Chasing the Swallow, Truth, Science, and Hope for Pediatric Feeding and Swallowing Disorders, that I self-published and is available on Amazon. And I do receive royalties from the accompanying 13.5-hour CEU for the book from speechtherapypd.com. So yeah, I stay pretty busy, but those are my financial and non-financial disclosures. If you ever have any questions, please feel free to reach out. All right. Thanks, y'all. Bye.